All right, now is time. So much fun. Time to introduce our speaker today. Dr. Shearer is a patient care line manager for the primary care mental health integration service at VA Portland Healthcare System. Her areas of expertise include using telehealth technologies to provide and increase access to mental health services, telesupervision, integrated health care. She provides telehealth training and consultation throughout and outside of the VA healthcare system. Her academic interests include mindfulness and acceptance strategies in the treatment of psychological issues related to chronic medical conditions, pain, telesupervision, and all things related to telehealth. In addition, I may take this moment to embarrass her for a moment because I've had the privilege of working with Dr. Shearer for, let's say, a few years. And it has been, I'm just always stand in awe of what she's been able to accomplish. She's an outstanding clinician, outstanding supervisor, outstanding program lead. She's doing really innovative work that's having impact on the national VA level and is really a national expert on telesupervision. And I call her a good friend. So it's all great. So with that, I'm going to exit stage left and turn it over to Dr. Shearer.
Thank you, Dr. Felker, for your warm and generous introduction. It is such a joy to be back with you all today, and I am just loving seeing all these messages about where people are from. I think it really highlights the spirit of what we're doing here and how we're harnessing technology to improve access to resources, to care, and share knowledge. So it's just very exciting. I was looking back at when I presented on virtual group-based care for telebehavioral health, and it was back in 2020. So it's been 4 years since we talked about this topic, and I'm going to share a little bit more of a literature review and some changes in the types of care offerings that are being done virtually. So I'm excited to present on that. And like Dr. Felker said in the disclaimer section, my lens is from working in a federal system within the United States. So that affords me certain opportunities and also limitations based on the structure of this system. And so please do translate this to the places where you are working and the local regulations, resources, etc. All right. So today, my hope is that we can talk about adaptations that are needed and really focus on, you'll hear me say this a number of times, function rather than form. So whatever we are doing, whatever modality we're working in, we want to make sure the function of what we're doing is still the same, regardless of modality. And so we may have to adjust to ensure that we're meeting those functions. We'll discuss privacy, confidentiality related considerations, and then last but not least, really dive into strategies, ideas. I have a number of images that I've kind of taken of, I had to borrow some of my kiddos' toys to pretend like this was a group since I didn't have patient permission to share images, etc., so that you could kind of see what some of these things may look like. All right, so at this point, the types of virtual group offerings have expanded quite a bit. I'm going to show some examples on the next slide, and perhaps many of you are already engaging in this type of care, but I'm hopeful that some of this content will help you kind of think a little bit more creatively about what you're doing and what you might like to do. So certainly we want to think about location. People could be joining a group from a local clinic, perhaps a remote clinic that is employing a virtual telehealth setup to connect the person in that clinic with a main hospital or a metropolitan area. A participant could be in their home, or you could have a group that has a mix of people at remote clinics, in their homes, et cetera, et cetera. The facilitator could also be in clinic like I am right now or at home. And we have the ability to do all of those things. I will put in a caveat that it can be tricky depending on the layout of rooms and how the cameras are set up to really have a group integrated where you might have people that are in a room with maybe one or two people from their homes. The logistics can be tricky, so it really merits practice and seeing if the group processes still translate depending on hybrid type modalities. And then certainly the various types of group interventions. So we'll talk about things as mild as psychoeducational groups or classes, drop-in type classes, to more evidence-based therapy groups. Excuse me, I still have this little tickly cough that comes up every now and then. I'll try not to blast the microphone with a cough here and there. Supportive groups or really group processing type interventions. And we'll also talk a little bit about intensive outpatient groups or even virtual residential and inpatient groups, because with COVID, we've had to do all of the above. And now as we move kind of into this peri-COVID or post-COVID era, we're really needing to look at what is functional, what do people want, what's actually going to improve access and engagement, and what just makes sense. So really trying to be pragmatic here. So this slide is just a snapshot of the various types of groups and classes that we have at the VA right now. So for folks that are international, VA is Veterans Affairs, and it's a national federal program of hospital type settings, and there's a lot of variability in what's offered. So I looked at several different VA sites to kind of see what they offered and put them all in here. So you can see I put them in categories related to more health and wellness, so exercise, nutrition, yoga type classes, to more support or drop-in type groups where we might be advertising to a community and bringing people together for connection. Because this is something that among our rural veterans and certainly within the COVID timeframe, people felt really isolated and we wanted to bring them together. And then we have more skills type classes that are going to be more psychoeducational, to family and marital therapy groups, evidence-based therapy type groups. I didn't list all the different types of CBT groups and ACT groups here, but I just put those in as categories. And then to share some of the more intensive outpatient group programming. So what is meant here would be group programming that's multiple times a week and usually for an hour and a half to 2 hour kind of chunks of time to mimic what it would be like if someone was in an intensive outpatient therapy program. And then last but not least, we do have several virtual residential or domiciliary programs that have a number of groups that are kind of slotted one after the other. So a mix of, or a program created of some psychotherapy groups, educational groups, and recreational therapy groups. And the veterans have a schedule so they can actually participate fully virtually. So let's talk a bit about the literature base. So some of these references were from my slide deck back in 2020, and I reviewed and included research that has been done since that time. By and large, the findings remain the same. So when I presented in 2020, the evidence was really still burgeoning. We were still learning. The existing literature was kind of mixed in terms of the types of virtual technologies used. So some of the literature was focused on telephonic type group interventions, but what we are looking at here is video-based virtual group programming. So we're kind of narrowing it to that. But so far, the literature points to virtual behavioral groups being feasible, being highly satisfactory for the attendance and a high rate of acceptability. It seems like when behavioral outcomes are assessed, so perhaps PHQ-9 scores to look at depression or chronic pain measures, et cetera, they're finding them to be equivalent to in-person group programming. They're found to be safe with adequate safety measures employed. Some of the more recent studies have found that the therapeutic alliance type variables or group cohesion variables are equivalent. And I wanted to kind of frame it this way to say that our technology has stabilized more recently, and we have more ability to have secure video-based formats for group interventions with some of the I keep on wanting to say bells and whistles, but some of the apps and add-ons that really improve group processes. And we'll talk about that later on in the presentation. The challenges kind of remain the same too, and it's mainly related to the ability for people to have access to the technology, internet bandwidth that is enough to have a stable video connection. We did some troubleshooting just this morning and had to do some restarts, etc., to make sure that the sound quality was good. Resources related to actually having a device that has actually decreased some because the kind of permeation of video approved software and ability has increased. And then the big one is training, both on the staff side. So having facilitators have adequate training to really understand the nuances of the technology, the abilities of the technology, and also to be able to troubleshoot in the moment, but then having a way for participants to practice technology, perhaps some training themselves, or even a caregiver support in certain situations to get them kind of logged on. Those seem to be the biggest challenges. All right. So this is what we're going to go through piece by piece. We're going to talk about considerations when setting up a virtual group. We're going to talk about privacy and consent type concerns to think about, how one might disseminate materials, both kind of in preparation for a group and as well as once it's going on, emergency planning, and then facilitation. Okay, so I think the setup is the perhaps taken for granted piece. So as Dr. Felker mentioned, I in my current role am in more of a supervisor or managerial position. And what is really difficult for staff when setting up a virtual group is that it does take more effort to get the setup done well. Many staff were used to in-person models where they would have a roster and their patients would show up and, and just go right into the group room and take it from there. Whereas having a virtual group, kind of getting people links to join, the platform ready, getting them to consent and have some education does take longer initially. So I would defer to your facility related to what kind of platform you might use, as long as it's a HIPAA compliant platform with encryption and is secure. And it has the video-based teleconferencing technology that seems to work well. And then your own procedures. So I listed here a bunch of potential additional features, the bells and whistles, as I'm calling it. They all are a little bit different depending on each platform. So that is something to think about. For example, most platforms have a chat function, but not all platforms have a chat function that allows the participant to only message the facilitator, for example, or even to message each other. And it's something to think about when you are considering the type of group that you are engaging in and how you want that chat function to work. So for example, my groups and classes are primarily psychoeducational classes right now. And so the chat is really to ask me, the facilitator, questions to make sure I'm covering it, because the class is more designed for me to present information to the participants, not for the participants to really interact with each other. So you have to think about the function, again, of these add-ons. View settings will show a couple of different views. Do you want the participants to see each other as kind of Brady Bunch squares on a screen or Hollywood squares? Or do you want the facilitator to be the main focus and have the others viewable as kind of a small banner or not viewable at all? whether or not cameras track. So I have a camera that does not track, so I can move, and I'll show an image where I'm doing a acceptance and commitment therapy demonstration where I don't want the camera to track me because I'm trying to show something, but some automatically will track as I'm moving. And then various presenter options related to sharing. Will it share your screen? Can you share only parts of your screen, like a window, for example? If you share a video, will it share the audio? There's a lot of nuance related to practicing in these functions. And then something that we noticed with our technology is the VA has its own video-based platform, but I think it was last year or the year prior, Apple released a new feature called reactions, and this might have impacted some of you, where if a participant maybe did a thumbs up or had some kind of reaction, there would be a image on the screen. And it was really disruptive, both in individual video-based sessions as well as in a group. And it was related to what Apple iOS had put out. So our kind of technicians had to revamp and figure that out and eliminate that ability. But that goes to show that technology is constantly changing and improving, and we have to be aware and practicing. I skipped over this one, but another feature is whether or not you as the facilitator have the ability to disconnect participants individually or even all together. It's recommended that, when you end the group call, that you can disconnect everyone so that folks aren't just kind of left on the call without monitoring. In some situations, that might be perfectly appropriate, but again, really thinking about the function. If we were in clinic, we likely would kind of usher people out of a group therapy room or group kind of behavioral health room to make space for the next offering in that room, and wouldn't have people kind of lingering on more. And yet maybe you would if it were a more of a supportive type group, right? So again, function is the most important piece. And then last but not least, we have to think about the emergency related applications. Is there a way to connect with someone in the group individually if there's an emergency, where you might want to disconnect everybody else, but keep that participant on to resolve that emergency, whether it be a medical or behavioral emergency or other applications like that. Okay, we're going to go into a little bit more detail on some of those. And I'm just peeking at the chat here, and it looks like we're getting things over to the Q&A. Thank you for that. So when you are inviting a participant to a virtual group, it's important that all participants agree to be a part of a virtual group. And this came up a bit more when we were practicing using hybrid type groups, where some of the participants might have been in clinic, in kind of a secure clinic location, and some might have been home-based. Even the veterans or participants that were in the clinic had to agree to engage in a virtual group, because if there's anybody that's coming from there or joining from a home environment, it increases the possibility for a breach in confidentiality or privacy. So certainly having buy-in and agreement that everyone will be joining from a private location is important, but also highlighting that we're all agreeing here that we're not going to do screenshots or recording or things like that, because not everyone has consented to that. Some platforms have built-in technology to prevent on-screen recording or screenshots, but it's not yet common, and it's another one of those features to look into when you're weighing different platforms. Typically, most facilitators tend to go through kind of the group buy-in, assent, and agreement over the phone. It's really great if it can be done virtually, because if you can see a veteran, or I keep saying veteran because that's my lens, a participant virtually, you get a sense of where they will be connecting from, and that's always a good question to ask, and what variables they're contending with. Are they connecting from a place that is very loud in the ambient environment? Are they easily interrupted? Do they not have a private location, so they need to connect from inside their car on a tablet or phone or something like that? All of those things could be assessed and troubleshooted one-on-one in a virtual session. At the VA, we have a national group telehealth agreement that is disseminated to all group participants prior to engaging, and we have a workflow to send it and then pop it into the electronic health record. And it's something to consider for outside agencies as well, to have some kind of agreement in writing that can be referenced. So I'm going to show a couple of examples. So on the next slide, I have an example here. It's really small, so I'm hopeful you can look at it at a later time and weed through it. It is an example of an email or letter that is sent to a group participant with some details about when it is, what it is, how to troubleshoot technology preceding the group, the type of platform that's being used, a little bit of what could go awry and how to resolve it, and a reminder to mute initially to reduce background noise. And then certainly the facilitator would have their contact information here. And then on this slide, I have a copy of the VA's group telehealth agreement. And again, really small print here, fine print. I promise when we send this out to group participants, it's on regular size font so that they can read it. No kind of tricky fine print fooling here. But I wanted to share it with you all in case you want to adapt something like this for yourselves. So there's a blurb about confidentiality and about how important it is to preserve the confidentiality of all those that are joining the group and kind of the onus on the participant to uphold that. Some risks that there is a risk that someone could record or attempt to record, and we can't control that, but we're all acknowledging that we won't do that. Privacy, that this is voluntary, that you can withdraw at any time, and that we're not going to force anyone to do something that makes them feel uncomfortable. There's a little bit about being respectful to others and supportive of others, and kind of being mindful of language that's used, and then to be safe in their behaviors. So again, kind of how they're going to interact in the group setting. This isn't a consent form. We don't obtain signatures, but we do give it to all. And we verbally ask if they agree to these conditions, and we write that in the electronic health record. All right. So this is kind of a review, right? So when you invite someone, it's great to orient them. It's really great if we can do that kind of orientation over a video call. That's not always feasible based off of clinic metrics, time, et cetera, but to really in that orientation go over confidentiality and privacy, you might want to encourage headphones or something like that, etiquette, treating this video-based group like an in-person group. We had a little bit more of that when we were rapidly transitioning to group-based care with the onset of COVID, with people kind of eating during groups or wanting to drive during groups, et cetera, where we had to kind of say, hold on, this is still an appointment that you must attend, and not must, but you must conduct yourself like you are going to a behavioral medical appointment. And then knowing where the participant will be physically is critical in case there's an emergency, medical or behavioral emergency, so that you can send the appropriate services to that. So let's talk about emergencies next. So typically the emergency plan is to contact 911 or whatever the emergency services are for where you are providing care, and requesting those relevant services to be dispatched. It's important to remind folks, hey, if there's an emergency, this is the plan, that we'll call 911. If you have the ability, what we recommend, like I mentioned before, is to disconnect all the other participants. Hey, we're having an emergency here. I'm going to disconnect everyone else from the call. I will follow up with you all later on today, and we'll make a plan. And to keep the person that is having the emergency on the line. We don't want to kind of disconnect everyone and then have to try to get a hold of that person and not know what's happening. And then to stay on the line until emergency services can be connected to the person in need. It's really nice if there is a colleague or assistant that can be made available to assist, perhaps with calling while you are on the line, although you can often kind of stay on the line, mute yourself and call, etc. In some ways, having this be done virtually allows us to actually harness technology in a way that might be challenging if you were in the room, and trying to manage that. Okay, let's move into facilitation. So as much as I mentioned that technology has improved and stabilized over time, it's still always good to budget extra time on that first day and plan for some kind of hiccups. So as a practice manager, we try to structure our groups and classes here to have a orientation session as the first session where we are orienting to the class. So kind of sharing a little bit more about group etiquette, a little bit more about expectations. I often will do a little primer in my first session to say, hey, this is a video-based class. Sometimes it can be tricky to come off mute. Sometimes being off mute causes feedback. So I'm going to rely on a lot of your visual. I'm going to rely on a lot of nods or no's or yes, no, to kind of see where we're at with the content. It's great to prep and have telephone numbers handy for easy access, especially for those emergency type situations, or even a co-facilitator so that one person can troubleshoot with people that may have connectivity challenges and the other can get going with the class or group. Not all platforms have an audio option as a backup, and that's something, again, to think about with that form versus function piece. So some groups and classes are perfectly workable to have some people join via audio as well. Some of them are just not going to work as well. So for example, in a sleep orientation class that I do about insomnia, I present a lot of information visually. And so if someone is having a tech difficulty and they're not able to join via video, I share with them it's going to be pretty dry and hard to follow if you can't see what's going on as I discuss sleep cycles, etc. So why don't we connect afterward and try to get you into the next one and get your video going. All right. So I'm going to share an example that I use when I don't have a co-facilitator. And I share this because sometimes we have groups and classes where people are trickling in for the first maybe 3 or 4 minutes. And it's really nice to have sorry, I'm in clinic, so I have a little pager with me. I'm gonna make it silenced. It can be really helpful to share a screen to say, hey, we're here. You're not probably gonna hear much going on. We're getting everyone connected. Please stand by. And it allows for that buffer time. The technology that we use in the VA also has an additional feature related to emergency services where the facilitator validates everyone's physical location. It prompts participants to enter their physical address and kind of contact information when they join the video call. And then the facilitator kind of goes to make sure that the addresses are entered correctly. I have, prior to the class, a list of the addresses so I can make sure. And that just makes it so that we can ensure that we're going to send dispatch to the appropriate location as quickly as possible. So having a little buffer time helps me make sure that I can check people in and do that verification. Some products or platforms allow for measures to be completed or at least links to be sent so that measures could be completed and sent in. And that's another thing you can do during that buffer time. So like I mentioned, I share my screen here. I say, hold tight, we're getting everyone connected. I usually will leave my camera on so that I can kind of wave at people and say, hold on, I'm here, you're in the right place, so to speak. But I will mute myself while I'm clicking away and making sure people are connected. All right. So not all platforms have the ability to lock the class, but some do, where most platforms you send out a link to join, or that link is sent directly by the kind of platform. So in theory, anyone could join that had that link, whereas some platforms have a feature to make sure that even if you have the link, you can't join once the session is locked. Those types of security pieces are good to know about your platforms, and then to highlight with participants. This is how we're keeping our information here safe. It's also not as necessary for perhaps more of the wellness type classes where it might be more of an intervention where a facilitator is teaching how to do something like an exercise program, etc. You might find that when you're facilitating, you have to be a little more proactive and call on participants. How is it going, Dr. Felker? How is this experience for you, etc. Some platforms allow you to kind of showcase names. So you can see here in our Zoom call, it has my name listed there, and that can help allow for more of that calling on people, and people can usually adjust kind of what their name says. You might have to allow for more pauses to allow people to kind of think, decide, I think I will participate, unmute, and then participate. And it can be tricky to toggle the different, muting, unmuting. So you might have to be a little more proactive of, okay, I think I heard someone say something here, go ahead. Okay, now and do that kind of directing. And then test all of the features beforehand, because there's nothing like trying to share in the moment and realizing, oh, wow, my audio doesn't work when I share. How do I troubleshoot that? What can I do? And even having a backup is really great. You can kind of see in my blurry background that I have a whiteboard that is supposed to be mounted here and is something that I can use in a pinch if my sharing screen isn't working for whatever reason. And here's where I really kind of highlight the form versus function again. At our core, we should be thinking about how this would look in person and what we're trying to achieve in person. So how it looks may not be the same, but what we're trying to achieve likely can be translated in thinking about how we do that. I often find that I, as the facilitator, have to mute everyone because the noise can be rather challenging to manage. And so recommending headphones, also talking about, hey, I'm going to mute everyone. That doesn't mean I don't want you to participate, right? Please, give me a signal or come off mute and participate. I'm just doing this to manage the noise piece, but we do want people to do that because it can be tricky to learn how to unmute, mute, and keep doing that. And like I said before, those nonverbals and coaching around that, I tend to be very expressive in my little virtual box that I have. And I coach folks on how to do that and make sure that they are doing that in a class. So I want to go through a few examples. You're going to see some images here of different layouts. And again, this is the platform that we use in the federal system. Not all platforms are the same. And I know many have even more bells and whistles than what we have access to here. So just want to showcase some of those. So in all of these examples, you're going to notice that we've got myself here, and then my co-facilitator is Dr. Coffee right here. And we have 4 group participants that I borrowed from my kiddos and arranged. I kind of ran to the limit of the tech devices I had to join this group. So we have a small group of 4 participants and 2 co-facilitators, but you can kind of see what this looks like. So in this example that I'm showing, we have the visual layout to show the 2 co-facilitators kind of spotlit on the screen, and then the row of participants on the bottom. It's a little bit hard to see here, but we also enabled names to show so that people would know kind of how to address each other if desired. And in our platform, there's a little lock symbol I can show here with my mouse maybe to show that it's encrypted on the right. This next slide is an example of more of a psychoeducational class. So as I mentioned before, I run a healthy sleep orientation class. It's a one-time class where we go through a lot of psychoeducational content, a lot of visual content. So I highlighted some notes from this for you to kind of think about. One is the image, right? So you can see that I'm sharing my screen and I'm sharing an image about sleep stages, which makes the visual of me pretty small in the corner here. Because this is psychoeducational, not really a class where the participants are interacting very much with each other, um, most of the time I can keep the whole class on mute and rely on the nonverbals and then unmute at the end to talk about treatment options and questions. It's self-referral because it's pretty low baseline in terms of anyone who's having sleep difficulties can come to this class and try to, learn more about what they can do. So also minimal screening. We have a system where a participant who's interested in the class, they might see the flyer, they might see it on a website, they call our scheduling line directly. The scheduler sends them the group telehealth agreement and insomnia severity index, which sometimes they complete, sometimes they don't. It's not mandatory, but the group telehealth agreement is. And the scheduler then documents that they sent the group telehealth agreement and the chart and schedules them directly with the class. The scheduler, excuse me, also sends them a packet with a letter that you kind of saw the bones of earlier and handouts for the participant to reference during or after the class. If a participant doesn't show for the class, then they're called by the scheduler and invited to, join a next iteration or not. It's up to them. So you can see it's a very kind of low intensity type class. We use a program called Secure Messaging, which allows for email type communication. And then we also use these BHL Touch and mental health checkup are two different ways that we can collect measures digitally. And those are really helpful to allow for measures to be sent. It's not mandatory for this type of class. And this would be one where we do a lot of screen sharing, we use chat, and we do play with the layouts to kind of make us small so that the visual screen is mainly the document that's being shared, and then take that down and show us again. All right. This would be kind of the next step up. So an example here is for a 4-session cognitive behavioral therapy for insomnia class. The way we had this set up was that the orientation class that you saw prior to this was the precursor or prerequisite for this class because it set the foundation. So the screening is still pretty minimal. It was the group telehealth agreement that they would have already done, an insomnia severity index, and then they essentially would have received all those materials from the prior class, inclusive of a sleep diary, and would have been told at that class, hey, if you want to do the more intensive cognitive behavioral therapy for insomnia, let's have you fill out that diary before such and such date, which is the first date of that class. So that packet has already been sent to them. Now, if a participant no-shows this one, the facilitator would reach out to see, are you still interested? Are you not? What would you like to do? And determine the next steps because it becomes more of a clinical conversation. This is where that secure messaging type platform and BHL Touch or mental health checkup, any kind of way to get the measures back and forth becomes crucial because for cognitive behavioral therapy for insomnia, we would be doing more regular measurement-based care, collection of homework, etc. But the layout is still similar, right? So this is an example of me sharing the sleep diary and showing how to calculate sleep efficiency. And there's still some screen sharing, chat, etc. All right. And so the next level up would be an example of perhaps a class for a virtual intensive outpatient program. a residential or domiciliary program. So this is a little snapshot of an intervention from acceptance and commitment therapy for chronic pain group that I ran. So this class, well, it's not really a class. This would be a group, really a therapy group. We met twice a week for 90 minutes each, and it was 6 weeks long. So really an intensive outpatient type program. Or we paired this with this class was ran in between a physical therapy class and another psycho ed class, and became part of a kind of a day program for a residential chronic pain treatment program. So referrals for this came from the outpatient mental health clinic. So someone who was already engaged in video-based care with a therapist or medication management prescriber would kind of say, oh, this veteran or, excuse me, participant is appropriate for this class. I have seen that they are willing to engage. I've kind of done some tech setup with them because I'm working with them individually, and they would refer directly. So there's minimal screening from my perspective. I would encourage the referring provider to complete the group telehealth agreement, but I would have already known that they were kind of able to engage virtually because of their prior experience. Again, an assembled letter, and for this one, we had a workbook for participants to use and accompany the class. The workbook had activities kind of in written form as well as measures and homework in it. Similar to the prior example, if there were a no-show, the facilitator would provide that outreach to determine what's going on and what's needed. For this one, the secure messaging, et cetera, were not as crucial because we kept everything in this workbook and did more of the kind of check-in and homework within the group rather than in between. But a lot of screen sharing and chat. So you can see this was one where I was doing an example here of how pain can increase based off of avoidance of that pain, and this balloon was increasing and harder for us to engage. But you can kind of see how in some ways a visual format can bring functions that we might not be able to experience as much in person. You know, I could blow up a balloon in person, but I would still be there and much easier to engage with in the room versus in the screen. This balloon physically takes up so much space that it becomes difficult to even see me, right? So really thinking about the function of the exercises we're doing, and are there adaptations that are actually even better over a virtual format? That's kind of the key takeaway point. For these longer classes, we really made use of frequent breaks, mixed and active movement. I would co-facilitate with a physical therapist for some of these classes and kind of intersperse those exercises within the content. There's a lot of ways to be flexible, and in these group modalities, you can actually have a facilitator that's not here in clinic with you, and they could be across the country or even the world and bring in an expertise that may not usually be as accessible. So I wanted to highlight the various levels of examples in those classes and showcase kind of how we can do these things. So that is the content that I have. I'm going to punt to Cara about some of our closing pieces, and then let's answer some of these questions that I see in the Q&A after that. There we go. I was having a little mute toggle trickiness. So thank you, Cara. It gave me a second to read through some of these questions. And I had one last slide that said thank you, so I do want to make sure I'm saying thank you to everyone. These are awesome questions. So I'm seeing a general theme about the location and 911. Oh well, let me go time frame. You know, there isn't that I saw when I looked at the updated literature. There wasn't a whole lot of examination on adolescents. So I will say that far and away, the literature on virtual groups was primarily adults. I think I may have seen perhaps one or two, but I did not attend to those as much. So I would encourage you to look into that piece about adolescent care. And I did see that in one of the Tele 301 or 401s, there was a specific webinar on adolescents and children. So that might be a great one to review as well.
Yeah.
And then similarly for mental health first aid, I know that there are all kinds of trainings. There's a lot of trainings related to suicide risk assessment and management and safety. And some of those were on the Tele 201 to 501 series, which would be great to go through because the emergency procedures can be a little bit nuanced. I find that it's really important and rich data that we can get from their home environment. And so I would encourage those. Okay, so let's dip into some of these questions that are a little bit about 911 and kind of what to do in a crisis, as well as getting the information for the participant's physical location. So let me kind of peel it back a little bit more in that it is crucial to have the participant's exact physical location prior to the group environment. We would never want to ask where they are located in that group setting because it violates their privacy and it would be a safety risk for them. So we want to make sure we get that information beforehand, which is why it's really helpful to have a phone assessment, at least, if not a virtual assessment, to say, hey, this is the address I have for you on file. Is that where you will be? If you're going to be somewhere else, I need to know that in case of a medical or behavioral emergency. Because sometimes they'll say, oh, I'll be fine. I'm stable, don't worry about me. But sometimes saying it could be a medical one too. If something happens to you and I see that you're suddenly unresponsive, I need to get emergency services to you and I can't be delayed by trying to figure out where you are. So people are usually very amenable to that. At the VA, we have a policy that if someone refuses to disclose where they are, we won't withhold care, but we want to be very explicit that I may not be able to help you if something happens to you if I don't know where you are. And to have that kind of nuanced conversation before the group or class. And then I, as the facilitator, have on my roster of who I'm expecting, I have their address, their phone number, and their email address. I don't share that with the group, but I have that at the ready. I have had to call 911 once. It's so rare, which is a good thing. It was for a medical concern. What I did was, and for that one, thankfully the participant was able to indicate, something is happening, I need help. And so I very quickly told the participants, everyone, I'm going to disconnect you all except for participant so-and-so. I will call you this afternoon and we will make a plan. And then the platform that I was using had the ability to disconnect people one by one or all at once. And I disconnected everybody else one by one. I kept the person with me on the call to kind of see what was happening. I called 911. The platform that we use has the ability to, based off of the physical location of the participant, which I have validated, it'll give me a direct number for the local dispatch, because that's a question that came up later on is, do you call 911 or do you call the emergency services for where the person is locally? So we do have that technology and not all platforms do, but I was able to call the local dispatch and get the services, the appropriate services to the participant. I was actually able to stay on the call until the dispatch showed up. So I actually had that kind of handoff to dispatch. And then I spoke to the other participants who actually expressed gratitude to say, I'm glad that that person is okay and that they're being cared for. And we were able to proceed. So it was thankfully a good example of a positive outcome. Now, it's a lot easier if there's a co-facilitator, because the co-facilitator could be the one that calls 911 while you are engaging with the participant. or the co-facilitator could call the person that is having the medical or behavioral emergency, and once they're connected, they could be disconnected, and then the other facilitator can continue on with the class or group. So there's various ways to do that, but that would be an example of how I've managed it in the past. And like this anonymous comment here, when there's a lot of people in a group or class, it can take a long time to ensure that those addresses are there. If it's the type of technology I was describing, the participant pops in their physical location when they enter, and then it's the facilitator that's just validating to make sure that the address is entered in correctly and that there's a local emergency dispatch number for that area. Otherwise, I would say that you would have to collect that information beforehand and trust that the participants are joining from the location that they disclose to you. You might, in an orientation, say, if you're at a location that is different from what we talked about when we were, inviting you to participate in this group, please message me directly if you have a feature that allows them to chat only to you, right? Because you don't want them to share their location with everyone. Okay, so then this other question is about what to do if someone has a non-participant in the environment. Yes, this can be very tricky. And part of it is that initial discussion in the screening with the group telehealth agreement that they are agreeing to be private and only them. I've had many situations where a participant has asked for a caregiver to join them in the class. And, we typically allow that, especially for these orientation type classes. And then I build that into the group kind of etiquette initial piece to say, some of us have caregivers present with us. We're all agreeing to be private and to keep the content here confidential. I did learn the hard way that you have to be very explicit to say this is essentially a therapy type group or class, which means this is only for you, and we have to be respectful of others in the environment. One time early on, I had a participant bring a child with them to class, and that wasn't appropriate. So I did, in the class, I said, sir, we unfortunately cannot have children here. I'm going to go ahead and disconnect you for this class, and I will call you at such and such time so we can make a plan. And we kind of moved on from there. I think in terms of legal ramifications, it's more of if they're engaging in something that is not approved with the group telehealth agreement or the agreement kind of set forth, to kind of say, hey, this isn't what we agreed to, so I'm going to go ahead and disconnect you, or ask that you are disconnected from this class, and we will kind of reconvene. We've done that for participants who maybe presented and it was clear that they were not in a private location, like a passenger in a car, for example, and to have that explicit discussion. And it models for the other group members that we're taking the privacy and confidentiality of the class seriously, and that we're going to uphold that, even if it may be a bit uncomfortable. And then the 911 piece about local versus national. Our program does allow for a check when you enter in the address. It validates it and gives a local number if there is one. Now, we serve such rural veterans that sometimes there isn't a local number or the address cannot be validated because they're so remote. And so we have to call 911. Sometimes that is the best approach for remote participants because their local facility may not have the emergency services that are actually needed. And so if we call the local facility, they might have to call 911 to actually get the correct services to that location. So I would recommend calling 911. Now, I did see that there is I'm sure, fantastic telebehavioral seminar on emergency procedures and 911, et cetera, that I would highly recommend for that, because there's a lot more to it than just this piece. Yep, and kind of similarly with people who are unhoused or have challenging living circumstances, that you kind of have to go with the policies that are, with the agency that you're with or locally. But I would have all of that kind of have all your ducks in a row prior to beginning the class. And that's kind of what I mean by the setup of the virtual classes tends to be a little bit more labor intensive and take more time than, say, an in-person class. And I see that we're over time, so I'm going to be really quick. Go ahead, Cara.
Well, I was just gonna say that we're over time. It looks like people are having to drop off for various appointments and things. So if
Right.
there's anything last minute, we can add it in, but otherwise we can
I
wrap it
think
up.
I think we got to most of it. I think it's
Okay.
just that there was just one piece about camera on or visual or not, and I really do in the beginning pre-screening kind of say, this is video based, so we're expecting cameras on and engagement. And if I can't see your face, I can't tailor the material to you, but that's really dependent on the type of class. All right, I'm gonna wrap it up there.
Well, clearly, we all want more of Dr. Shearer, so we'll be in touch with you again to see what else we can ask you to join us for. So thank you so much. As I said, this has just been an awesome, and I can see by the comments in the chat that everybody agrees with me that this was an awesome presentation. So thank you so much. And thank you all of you for joining us. We had people from as far away as Japan and Argentina joining us today, so that's kind of cool. We want to wish you all happy holidays and get some rest and enjoyment, hopefully with your families, or not, if it's better just to lay on a beach quietly or something like that. But anyway, enjoy the holidays. Thanks for joining us. We hope to see you again in January. And if you have any questions, of course, send us an email to the BH Institute email address. Okay, thanks very much.
Thank you.
Bye.